Welcome to Medicaid 101, a series presented by the Medicaid and CHIP Payment and Access Commission. The Medicaid and CHIP Payment and Access Commission, or MACPAC, is a nonpartisan legislative branch agency that provides policy and data analysis and makes recommendations to Congress, the Secretary of the U.S. Department of Health and Human Services, and the states on a wide array of issues affecting Medicaid and the State Children's Health Insurance Program, or CHIP. The purpose of this series is to provide educational content and highlight, where applicable, recommendations that the Commission has made previously. This is part 2 of Medicaid in Context and focusing on how the program is financed through federal, state, and local funds and how the types and amount of payments made to providers can be related to the financing structure. This presentation reviews our prior work on Medicaid financing and how states use different financing sources and payment structures to support the program and target specific policy goals like rural access. I'm going to start with the federal-state partnership and reviewing the structure of federal financial participation. Next, we'll examine the non-federal financing structure and the different ways that states finance the non-federal portions of Medicaid expenditures. Then, I'll walk through the different provider payment mechanisms and ways Medicaid funds are distributed to providers. Finally, we'll discuss the need for data on the cost of providers' financing of the non-federal share and the importance of considering both gross and net payments when assessing payment policies and how they relate to the goals of quality and access. Let's begin with some context about the federal-state partnership that forms the foundation of Medicaid. Since the program's inception, Medicaid financing has been a shared responsibility of the federal government and the states. States receive federal matching funds towards allowable expenditures, and each state administers its own program within federal guidelines. In calendar year 2023, Medicaid represented 17.9% of national healthcare spending, less than Medicare or private commercial insurance. Federal financial participation in Medicaid varies year to year, but typically hovers around 65%. Most recently, in fiscal year 2024, the federal share was 64.5% nationally, though this varies significantly by state. This figure reflects 1/4 of increased federal match following the public health emergency. The federal share for most Medicaid service costs is determined by the Federal Medical Assistance Percentage, or FMAP, which is based on a formula that provides higher reimbursement to states with lower per capita incomes relative to the national average, and vice versa. HHS calculates FMAPs 1 year in advance using a 3-year average of the most recent per capita income data from the Department of Commerce. While this formula typically provides budget stability, it also limits how quickly the federal share can respond to economic changes. FMAPs have a statutory minimum of 50% and a maximum of 83%, with DC and the U.S. territories having FMAPs set directly in statute rather than calculated by formula. There are many exceptions to the standard FMAPs, such as temporary enhanced matches for natural disasters such as Hurricane Katrina, or temporarily increasing FMAPs to provide additional assistance to states during economic downturns. There is no preset limit to the federal financial participation for Medicaid for the 50 states. The federal match for Medicaid administrative activities does not vary by state and is generally 50%, although certain administrative functions have a higher federal match. Higher match rates often apply to activities requiring medically trained personnel, information systems for eligibility and claims processing, fraud control, and administration of services with higher medical assistance rates. For example, design and development of Medicaid management information systems receive a 90% federal match, while ongoing operations of these systems receive a 75% federal match. Because states can establish their own eligibility standards, benefit packages, provider payment policies, and administrative structures under broad federal guidelines, variation in Medicaid is the rule rather than the exception. This state-level flexibility, combined with varying FMAP levels, creates significant differences in the federal share of total Medicaid spending across states. As you can see on this map, there's substantial variation in how much the federal government contributes to each state's program. States must undergo an estimation and federal review process to receive their matching funds for state Medicaid expenditures. To receive federal matching funds, states estimate their quarterly Medicaid expenditures beforehand and report these estimates to CMS. CMS provides federal matching funds based on states' estimates through a fiscal intermediary through the HHS Payment Management System, or PMS. States use these federal matching funds to make Medicaid payments to providers. Subsequently, states report actual expenditures to CMS, which reviews and reconciles states' actual expenditures and federal funds to ensure the federal government matches only actual state expenditures. Like other federal payment programs, Medicaid must measure and report improper payment rates under the Improper Payments Elimination and Recovery Improvement Act of 2012. Improper payments are not necessarily an indicator of fraud or abuse. They are often due to instances where information required for payment was missing or appropriate processes for enrolling providers were not followed. Through the Payment Error Rate Measurement Program, or PERM, HHS annually reviews fee-for-service claims, managed care capitation payments, and eligibility determinations to estimate the rate and amount of improper payments in the Medicaid program. HHS assesses 17 states per year on a 3-year rotation. The review year 2024 national Medicaid rate is based on measurements from 2022, 23, and 24. Medicaid paid an estimated 94.9% of total outlays properly, amounting to close to $580 billion federal dollars. The national Medicaid estimated improper payments are approximately 5%, or $31.1 billion. Missing or insufficient documentation accounted for 74% of the improper payments, and an additional 5% were technically improper, meaning they were paid to the correct beneficiary for the correct amount, but the payment process did not comply with applicable regulations and statutes. In total, most improper payments, 79.1% of them, were due to missing or insufficient documentation and technical issues, not necessarily payments to ineligible providers or services for ineligible beneficiaries. Next, we'll discuss how states finance their portion, or the non-federal portion, of Medicaid spending. Medicaid statute allows states to use multiple sources to fund their share of expenditures, including state general revenues, local government contributions, and specialized sources such as healthcare-related taxes. Contributions from local governments can also include providers operated by local governments, such as county hospitals or school districts. Federal rules require that at least 40% must come from the state itself, while up to 60% may come from local governments. The extent to which states rely on funding sources other than state general revenue varies considerably and may be influenced by how states have historically split financing with localities for functions such as education, social services, indigent care, and corrections. Local government contributions often take two forms: intergovernmental transfers, or IGTs, where local entities transfer funds to the state Medicaid agency, or certified public expenditures, CPEs, where local entities certify the total expenditures incurred for Medicaid services or administration. The non-federal share contributed by providers is frequently used to finance additional payments to those specific providers. Healthcare-related taxes, often called provider taxes, fees, or assessments, are defined as taxes where at least 85% of the burden falls on healthcare providers or services. States can impose provider taxes on 19 classes of providers or services, with nursing facilities, hospitals, and intermediate care facilities for individuals with intellectual disabilities being the most frequently taxed. These taxes must generally meet certain criteria. They must be broadly applied to all non-governmental providers within the taxing jurisdiction, and they must be applied uniformly across providers within a class. States can apply for waivers of these requirements if the tax meets statistical tests ensuring redistributive effects without unduly burdening Medicaid providers. In addition, providers cannot be held harmless through a direct or indirect guarantee that they will be repaid for all or a portion of the taxes that they pay. However, the indirect guarantee test does not apply if the tax rate falls within a safe harbor established under regulation. The safe harbor is currently 6% of the provider's net patient revenue. This slide illustrates a simplified example of how provider taxes work in practice. In this scenario, we have two hospitals with identical net patient revenue of $1,000 each, but different Medicaid volumes. Hospital 1 has a high Medicaid volume of $800, while Hospital 2 has a low Medicaid volume of $200. Each hospital pays a 6% tax on revenue, generating $120 in tax revenue. The state uses $80 of this revenue as its share to draw down federal matching funds. With a 60% FMAP, the federal government contributes $120. The resulting $200 is distributed proportionally based on Medicaid volume, with Hospital 1 receiving $160 and Hospital 2 receiving $40. The net impact is Hospital 1 pays $60 in tax, but receives $160 in increased payments for a net gain of $100. Hospital 2 pays $60, but only receives $40 for a net loss of $20. Provider taxes can be used to redistribute resources within the health system for states. These maps show the prevalence of provider taxes throughout the U.S. All states except one, Alaska, have at least one provider tax in place as of FY 2024. 38 states have at least one provider tax over 5.5%, approaching the safe harbor threshold of 6%. This figure shows the national distribution of Medicaid financing for different types of Medicaid payments in 2018. Overall, you can see that about 68% of states' overall Medicaid spending was financed by state general funds. However, disproportionate share hospitals, or DSH, and non-DSH supplemental payments are more likely to be financed by providers through taxes or IGTs. Next, we'll review how states distribute Medicaid payments to providers. Base payments are standard payment rates for services delivered to Medicaid beneficiaries, and they're typically fee-for-service rates set by the state. Supplemental payments, which we'll discuss further on the next slide, are additional payments beyond base rates to certain providers. They allow states to target payments for different purposes. Directed payments allow states to direct managed care plans to pay providers according to specific rates or methods. Many directed payment arrangements are similar to supplemental payments. Historically, supplemental and directed payments exist because base rates don't cover provider costs or address policy objectives like ensuring access, supporting safety net providers, or incentivizing quality. This table lists some of the different types of payments and how they're used to address various policy objectives based on the intent of the payment implied from the federal rules. For example, the upper payment limit, or UPL, supplemental payments allow states to increase provider payments to what they would have been paid under Medicare. For disproportionate share hospital or DSH payments, states are required to make additional payments to certain hospitals that serve a high proportion of Medicaid beneficiaries or other low-income patients. DSH payments can be used to cover the unpaid cost of care for uninsured individuals. As shown, states use supplemental payments across a variety of providers. Supplemental payments were 53% of total fee-for-service payments to hospitals and 46% of total fee-for-service payments to mental health facilities. The extent to which states use provider taxes and local government funds to finance their supplemental payments varies. GAO found in state fiscal year 2018 that on average, 66% of DISH supplemental payments were financed by provider taxes and local government funds. 22 states and DC finance between 80 to 100% of their non-DISH supplemental payments with provider taxes and local government funds. Similarly, in our analysis of states' directed payment arrangements, we found that states also use directed payments to increase payments across various provider categories, with the most payments going to hospitals. We also found that 53% of directed payment arrangements to hospitals in 2024 were financed in part by provider taxes. Overall, about half of all directed payment arrangements were funded in part by state general funds, which means that about half of directed payment arrangements were primarily financed by provider taxes or local funds such as IGTs. As shown in this figure, Medicaid supplemental and directed payments are a large share of Medicaid payments to hospitals, making up about 40% of total hospital spending. In fiscal year 2022, supplemental payments accounted for more than half of fee-for-service payments to hospitals, and in managed care, directed payments accounted for about 1/3 of payments based on annualized estimates. Rural hospitals are a critical source of care for rural communities, but they may often face financial instability. Many states use supplemental payments as a way to target additional funds to rural hospitals. In total, we identified 15 states that explicitly targeted UPL or graduate medical education (GME) payments to rural hospitals based on the narrative information reported to CMS or their Medicaid state plan. 11 of these states explicitly targeted critical access hospitals, which are small rural hospitals that receive a special payment designation from Medicare because they are often the sole provider in their community. Using provider-level data on non-DISH supplemental payment amounts, we found that states that explicitly targeted rural and critical access hospitals spent more and a higher share of non-DISH dollars on rural hospitals than states with no rural targeting criteria. States that explicitly targeted rural hospitals were about twice as likely to allocate non-DISH dollars towards rural hospitals than states that did not target rural hospitals. And states that targeted critical access hospitals distributed the highest share of non-DISH spending towards rural hospitals. Next, we'll discuss Medicaid's effect on providers. While supplemental and directed payments do increase provider revenues over what they would receive through base payments, it is important for stakeholders to also recognize that provider financing of the non-federal share ultimately affects the amount of revenue the provider has to cover the cost of providing services. The Commission has done prior work on the need for data and transparency on the sources of the non-federal share. The federal government does not collect information on the sources of the non-federal share in a comprehensive manner. Last year, the Commission supported a recommendation for transparency around the non-federal share. The cost of healthcare-related taxes and local government contributions to the non-federal share can reduce the net payments that providers receive. To illustrate this effect, this figure shows how taxes and contributions from local governments reduce the net payments that DISH hospitals received in 2011. While gross DISH payments reported on Medicaid audits in 2011 exceeded hospitals' costs for Medicaid patients, we estimated that taxes and local government contributions effectively reduced these payments by 11%, resulting in net payments to DISH hospitals that were below their costs of care for Medicaid-covered patients. Here's another example showing the impact of financing mechanisms on gross and net payments under managed care. For this example, we are using data for a Texas hospital. Texas collects and makes public Medicaid financing data at the provider level, similar to what we outlined in our prior recommendation. This illustration is valuable because it is a provider-specific example of many of the concepts that we've discussed here in this presentation. For this Texas public hospital, gross payments from the managed care plan were 128% of Medicare rates. However, after accounting for the cost of healthcare-related taxes and local government contributions, net payments fell to just 82% of Medicare rates. Medicaid is a federal-state partnership that is supported by a complex set of financing structures that have been built over time. Many of the payment structures that states use to address particular policy goals are tied to how states have financed these payments. The amount providers pay in taxes, IGTs, or CPEs can be seen as an additional cost that effectively reduce gross payments. It is important to analyze both gross and net payments when developing payment policy and assessing how these payments are linked to goals of access or quality.